So this week we're going to go through aortic stenosis, and again, this is a really, really commonly asked question. It's often done sometimes a bit badly. I think we'll go through a bunch of cases and just discuss and try and have good examples of what to mention as we go through it, and then we'll try, if we've got time at the end, talk about some of the more challenging aspects of aortic stenosis assessment. So why don't we start and kick off? I'll just start showing this one. Sorry guys, I've forgotten the name of the position I was going to do. Sorry guys, just one sec. I've forgotten the name of the bloody patient I was going to do.
Sam, this can come up as a written question.
Oh, absolutely, it's 100%. Absolutely could be a written question. I guess that's one of the things I wanted to be able to show you. Sorry guys. I thought yeah, so it's going to be TLN24. There we go. That's it. Yeah, let me just start again. Sorry, absolutely can come up as a written question. It's gonna it's gonna be along the lines of, tell me about aortic valve stenosis. Tell me how you're going to assess it. What are the severe parameters if someone's got severe aortic stenosis? What are the problems with trying to assess it in the various modalities? So normally a question like this will be in two parts, and there's quite a lot to get through, so you've got to have the things that we're going to go through very clearly written out in your mind about how you're going to answer it. So I'll try and do it with this one if it's the right one. All right. Where should we start off? Ravi, do you want to just take us through some, look at these pictures and try and take me through some of your thoughts.
So this is parasternal long axis view, which is showing very thickened left ventricular wall, and the left ventricle wall seems to be almost like kissing ventricle.
Hello.
Can you hear me?
Yeah, totally. Yeah, you're doing a great job. So you said it's the very thickened LV wall. It looks like there's a kissing ventricle. Yeah.
Yeah.
Then there is very minimal movement of the aortic valve. Aortic valve looks very thickened, and some calcification as well.
Yeah, nice. Keep going.
Apart from that, left atrium might be a bit bigger inside.
Yeah, good. Yeah, what's all that indicating? So you've got thickened LV free wall, you've got an enlarged left atrium, we've got this very calcified aortic valve, and I think we're seeing some calcification on other valves. Yeah. So what does that all sort of start telling you?
So my suspicion will be, LVOT obstruction, mainly at the valvular level.
Yeah, so it's not LVOT. If it's at the valvular level, remember, just trying to get the terminology nice and...
Aortic stenosis.
Yeah, fantastic. So if you've got that calcification, we're probably looking at some stenosis. But also, what does the thickened LV free wall and enlarged left atrium start telling you?
So it would suggest that there would be some diastolic, concentric hypertrophy.
Yeah, nice. And I guess it's also that this is something that has been around for a while. This is something that has built up, it's built up over time. This is not something that's happened like that. We've got chronic changes going on, and particularly degenerative disease. I think if it's affecting both the aortic valve and the mitral valve, suggesting that, some form of degenerative disease, calcification, thickening of the aortic valve, been there for a long period of time. Yeah, this is someone that's got raised left ventricle end diastolic pressure and chronic obstruction. All right. So what would you, if we've got chronic obstruction or chronically raised left ventricle end diastolic pressures, we know that we've then got to go and have a look on the other side of the heart as well for signs of pulmonary hypertension. So again, this is why I kind of like these questions, because it kind of, like aortic stenosis, because it brings everything together. We've got to think about both sides of the heart. We've got to think about systolic as well as diastolic dysfunction, and we've got to think about all the nuances of how we're examining these patients, and with echo. So everything starts coming together, which is why these questions are so popular. All right, let's start thinking about the other side.
Could I ask you, if you were showing that as a lead image for a...
Yeah.
Right. Would you say, just tell me what you see there, or
yeah, that's exactly how we'd say. We'd start off with
like, look, we want to focus on the aortic valve, or if you were doing a Viva in a primary, or there'd often be a sort of this is the direction we want you to go in, or would it be sort of, look, have a look at that and let's see where it takes us? What's more likely?
I think we'd definitely be leading you down the idea of looking at the aortic valve. We're only going to be able to show you about 8 pictures in total over a course. It's maybe maximum 12 pictures in one case. So I said we definitely got to get through 5 in 40 minutes. That's the minimum. We're going to prepare about 10, to be honest. And so we've got to get you through it. You can't have a pass or fail just on one question, of course. I mean, pass or fail the whole damn thing over one question. So we've got to get you through it. We'll definitely flick you in the right way. We'll be asking everyone the same question and the same kind of prompts and the same kind of candor. So yeah, definitely maybe it's the latter. We'd be pointing you towards the aortic valve.
Yes, the way you would answer that would be very vague and general. This is barosternal long axis view, my findings are. But if you said, look, answer that from an aortic valve point of view.
Yeah, I think it's probably, maybe I'll rephrase that then. So I guess this is exactly the kinds of, we'd exactly be giving you something like this. And the kind of answer that I'd be expecting would be, we'd be saying that this would be a 75-year-old guy who's hypotensive with a systolic murmur. We've done this echo. Okay. And I'd expect the candidate to look at this and say, because it's always going to be kind of critically care directed, of course, and you'd be expecting the candidate to say, well, I can see a thickened left ventricle that's got hyperdynamic systolic function, that's got significant calcification of the aortic and mitral valve, indicating potential also chronic degenerative changes. We've got a large left atrium. With the hypertrophy in the large left atrium, you've got to be worried about raised left ventricle end diastolic pressure and a chronic component to this process. I'm concerned about that aortic valve and the patient being potentially underfilled as contributing to this.
Yeah, and then work your way through.
And then I'm going to show you a picture that would look something like. Sorry, I can't find the bloody case I wanted to show you. Yeah, then I'd show you a picture that would look something like this, hopefully a little bit better than this. And I'd then say, tell me about this picture. Yeah. And I can't, so give me a go with this. So if I gave you this picture, and hopefully obviously be a little bit better.
I think that's a short axis view. The aortic valve is in cross section, and we're also looking at the right heart and the tricuspid valve. Yeah. The aortic valve is heavily calcified, limited and restricted motion. It would be difficult to do planimetry on that image.
Fantastic. So what kind of planimetry would you indicate would be severe?
Well, it's really, I suppose, ultimately it's a cross-sectional area, and the severe limb would be under 1 centimeter square.
Fantastic. And why do you say, if I gave you a better picture so that we could actually sort of even have an attempt at it, why would you or would you not use it in this kind of situation?
I think
And why?
it's an important finding in that it is a positive finding if it is under 1 centimeter, even if you are suspicious as to the quality of it.
Yep.
I think then you then will need to bring in other parameters to assess the severity, primarily Doppler related, but also 2D looking at sequelae such as the right heart and left
Yeah,
ventricle.
nice. Let's just stick with the planimetry for a little bit. So I guess in transthoracic, planimetry is, for me, I think, fraught with danger.
Yes.
Because I think the parameter is probably best suited to transesophageal because you can get better look at the valve. But I also worry about it because also if you've got the aortic valve that's opening, you've got to make very sure that you're catching it at exactly the right level. If you're a little bit off axis or you're underneath where the sort of the narrowest point is, you are going to potentially overestimate the size of the aperture. So
it's difficult to, yes, I suppose. Yeah, I would agree. But if you have if it looks narrow, you then have to prove that it isn't. But while if you were certain that it is not narrow,
I guess it's being able to, when you're talking in the exam, I guess all you got to do is obviously sound like you're being conservative. The examiner must come away thinking that you're not going to take one parameter, that's what I'm getting to, is you don't take one parameter to diagnose severe aortic stenosis.
absolutely.
I don't think you should do that for any kind of moderate or above valvular abnormality of any kind. You've got to be using all the modalities available. Very rarely we find that they all match up. And why do they not all match up is what you've got to be able to answer in the exam. We've got to be able to say why these things are inaccurate. And for planimetry, as I said, the things we've got to be able to say is there's a risk you're not going to be cutting at the right level, and there's a risk you're not going to be cutting at the right angle. With transthoracic, I'd argue you don't have good enough resolution of the image to be able to make accurate measurements.
Yep.
And with a bit of calcification, a few nodules everywhere, it can make it even harder. So I'm not suggesting we don't do it. I don't say you throw the whole thing out. I just suggest you've got to take that with a degree of caution. Cool?
Yep.
Nice. All right, who's next? So I guess the next kind of picture that we'd probably want to show you would be, yeah, let's go this one. So, Ramsey, so we talked about, so Ravi said right at the beginning that we got a thickened LV with hyperdynamic function. He also said in there, I think you said this, if you're seeing abnormalities in this plane, we want to go and have a look at it in another. So this should be the kind of picture that I want to show you to make you think that I was not off axis on that first picture, and to try and show that we've got a thickened LV, but also we've got this hyperdynamic function. So with that, I'd be wanting you to start thinking in your head that we've potentially got a cause for his hemodynamic instability of this patient in the fact that we're potentially underfilled. Can you talk to me through what kind of things, because we've talked a little bit about the importance of thinking ahead. The examiner wants you thinking at quite a high executive function. So if you've taken these two pictures and you think you've got someone with significant aortic stenosis, can you talk me through, what you think I'm going to show you next? Where do you think I'm going with this case?
I think one of the big things here would be, yes, it's a hyperdynamic left ventricle. Mm-hmm. And if this patient is still hypotensive, potentially looking at two things, whether this is just a vasodilatory phase that's actually causing this. Yeah. Is this patient actually hypovolemic? So obviously I want to know what the end diastolic dimensions of the left ventricle are, whether the left ventricle looks smaller in size, and what the stroke volume would be, because obviously this will impact on the gradients that we will get through the aortic valve. And this could potentially be just a paradoxical aortic stenosis, or paradoxical low flow, low gradient aortic stenosis.
Really nice, really nice. And you say, so you've got, if we've got a low stroke volume, you think that we might get a lower gradient if we've got a really, really bad stroke volume because this guy is horrifically underfilled. Is that what you're saying?
Yes, that's a possibility.
Fantastic. And now take me to the other end of the spectrum. Now let's say he's in vasodilatory shock and that this left ventricle is going hell for leather. on the other side
what
of the
we will get,
spectrum,
there will
what
be
do
a
you think?
very high gradient or a high, so a high velocity, high gradient state. But with your continuity equation, the aortic valve area will not be significantly reduced if there was no significant aortic stenosis. So, but this, looking at this particular picture, the aortic stenosis looks quite significant with the amount of calcification.
Yeah.
So yes, we would still get a high velocity. So the velocity would increase, the gradient would increase if the stroke volume was adequate.
Yeah, cool. So it becomes really important that we try and get an idea of what stroke volume is with this patient. So I think that's, you know, each case that we're going to give will have a, you know, a general direction that we want you to go in. And if, you know, if we're showing you a valve, you've got to take into account the hemodynamics. If we're going to show you an LV that's completely blown out and not moving, and the aortic valve looks, you know, looks like that, or maybe I can show you a better picture than that. Maybe I can't. You get the idea. If I show you an aortic valve that looks horrible and you've got a big blown out left ventricle, you got to know that we're probably going to be looking at the, you know, low flow states. So that means that all the valvular gradients are going to be lower. So just trying to think ahead like that, I believe is really important. Okay. So bearing that in mind, let's move on to the next one. Okay, Hatim, what are you gonna? Does this add anything to what we've been just talking about?
Yep. So this is an apical 5-chamber view, showing the heavy calcification of the aortic valve as well as the left ventricular hypertrophy with thickness of the wall. Still confirming the relatively hyperdynamic function of the LV with mild dilated left atrium. And so it's not adding much, but it's just confirming the diagnosis and just confirming the state of flow that we're expecting.
Yeah,
That
really
is
good.
relatively.
So, again, seeing that underfilled ventricle, very small end systolic volume, horrible calcification we're seeing in here. Interatrial septum, as you're saying, pushed over to the right, significantly raised left ventricle end diastolic pressures, even though the left ventricle is still underfilled, all pointing towards significant, you know, this is significant stenosis that we're looking at.
And we can start looking at the gradients across the LVOT and the valve.
Fantastic. All right, let me show you. All right.
So
Go for it. Whoever's talking, go for it.
So this is a pulsed wave. This is a color Doppler, and across the mitral valve. It's actually the cursor is just in the middle of the LV, as far as I can see here, and it's showing a gradient across the mitral valve aperture, which potentially could be an element of mitral regurgitation, although I can't see any color Doppler significance.
Are we doing a pulse wave or continuous wave Doppler?
It looks like continuous wave for me, but
Yeah,
I can see a cursor in the middle.
We get that little, so you see that there's two little lines there at the top in there, and the fact that in here we've got, it's not perfect, but you get the idea there's an outside area and inside looks dark.
Yep.
So this is pulsed wave Doppler.
So this pulse wave, yep.
Yeah. I'll just compare this with this one here. Oh, no. Yep. So this one here is on the right side of the screen. That's continuous wave.
Yes.
Well, you probably can't see it as well, but there's no little gate that we've got in there. There's no gate like that. And here it's all filled in. So continuous wave Doppler on the right, pulsed wave Doppler on the left.
Yep.
All right. Why is this relevant? And I know it's maybe a question for for someone who's about to sit the DDU, but what's the relevance of this?
So it depends on where exactly I'm putting the cursor and trying to identify the flow. Because in that context of the aortic stenosis, I would expect that there will be turbulent flow at the root of the aortic valve.
Nice.
Sorry, not at the root, at the LVOT. From
It's
the other
going to
side.
bring us through a nice thing about an idea about the Doppler angle.
Yep.
All right. So the next thing we've got to talk about when someone's asking how you assess the aortic valve, you've got to know the advantages and limitations of each parameter. So what's the advantage of continuous wave Doppler in assessing aortic valve stenosis? Why do we use it?
So we use it to identify the amount of turbulence that would be at the LVOT.
Yeah, and it's not the LVOT. For aortic stenosis, it's going to be obviously in the aortic valve.
And the valve itself, yep.
Yep. And what about the gradients that you can assess with continuous wave versus pulse wave?
So with the gradients, we can compare the gradient across the whole tract, which should be exceeding 4 to 1.
Yeah, if it's severe, you mean? Yeah,
Sorry?
so 4 meters per second if it's severe.
Yep.
We're assessing it
Yep.
very nicely. We're assessing all the way down that line for continuous wave Doppler. Whereas for
Yep.
pulse wave Doppler, what's good and what's bad about pulse wave Doppler?
It would be just the first of the point that I'm getting the gauge at. So whatever the cursor is aimed at, it will be just reflecting the flow at this point.
Very nice, very nice. So what do these two pictures show you then? So this is just north of the mitral valve leaflet, so it's sitting in the LV, and we've got this kind of looking parameter. What does that tell you?
So I'm not entirely sure.
No problem. Let's move on. So
obstruction.
do you want to talk, or sorry, Ramsey,
Are we looking at mid-ventricular obstruction? It's not exactly mid-ventricular, but it's just proximal to the left ventricular outflow tract, which could either be secondary to severe hypovolemia, or even because of hypertrophy, asymmetric hypertrophy of the septum.
It's really nice, well done. And so I guess with the continuous wave Doppler here, we're seeing the important thing that we're seeing here, Hatim, is this late peaking jet, right? So if it's systole from the beginning of the QRS to the end of the T wave, we've got the peak of this jet happening towards the end of systole. And I have that a little bit like if I have a hose pipe and I squeeze it till it's completely closed, you'd see that jet of water from going, a meter in front of me, it would go further and further and further out as I got narrower, and then it would stop suddenly, right? If I was squeezing a hose pipe. And that's what this represents, that in terms of meters per second, that hose pipe of water gets faster and faster and faster and faster and faster and goes further and further and further, and then suddenly stops off because you've got complete occlusion, and then the pressures drop off completely, or the speed drops off completely. And that tells me that we got some form of obstruction during systole, and as that ventricle is contracting down, because I'm here, I've got my pulse wave in the middle of the ventricle. As it contracts down, it eventually stops flow because of the complete obstruction, the mid-ventricular obstruction, as Ramsey was saying.
Yep.
All right, Ramsey. So what do you make of that then?
All right, so that's again a continuous wave Doppler going through the aortic valve. We're looking at the peak aortic valve velocity, which is clearly more than 4 meters per second. So again, indicating a high peak velocity, which is severe aortic stenosis.
Beautiful. So you got greater than 4 meters per second. What are the other parameters?
Yeah, the other thing is also the mean gradient is more than 40, which is again another indicator of severe aortic stenosis.
Very nice. Perfect.
I think it's MR jet. It's not aortic.
Interesting. So I guess we can start now talking about, did everyone hear that? So there was a question, are we looking at an MR jet or are we looking at a aortic jet? Okay, because it's going to be important, right?
Yeah, it doesn't look like aortic.
And how can you tell the difference between mitral regurg and aortic stenosis?
The pressure gradient's one of them.
Pressure, okay, pressure gradient, and tell me a little bit about that.
Yeah, so so what we're looking at is a gradient of a peak gradient of 100 millimeters of mercury, which, I mean, of course, you could get that with the mitral valve as well. You would get a peak velocity of around 4 to 5.
Yeah, nice. So normally with a normal functioning ventricle, you expect the pressure to be greater than 4 meters a second. And that's what normally we see in a mitral regurg jet. It's going to be greater than 4 unless the LV is completely hopeless. And so you expect it greater than a mitral regurg, and maybe that's why we're saying it's greater than 4. We're also going to see it in severe aortic stenosis.
Yeah, I agree. I think, the one thing which is against MR is it should be the whole,
Yeah, and when we say against, yeah, absolutely.
Yeah,
So
it's only the early systole. So probably it's possible it's aortic and
Yeah.
it's severe.
Yeah.
Because MR should fill more cardiac cycles.
Fantastic.
Yeah.
So if you have a look where I put my cursor, does that kind of doesn't come out very well, does it? Let me see if I...
Cursor's right sitting above the aortic valve.
Yeah, the cursor is in a beautiful position. Since that
It's not parabolic in shape.
If I do something like that, can you guys see that we're sitting there with the isovolumetric contraction and relaxation time are smaller than in mitral regurg? Unfortunately, I don't think we've got mitral regurg here.
it's aortic.
So this is aortic. This is definitely aortic because we've got the isovolumetric contraction and relaxation time. And in mitral regurg, you'd expect that to be wider, in other words. Okay?
Just one thing, Sam. So there's one more trace inside of that. Is it alveoli trace?
Nice.
So,
Fantastic. And that's why this case suddenly becomes interesting. So we've got this other trace that's in here. And the question that we've got is that LVOT? So often you can see a little wisp. It probably looks better on this first one, if I maybe exit that. Probably on that first one there, you can probably see it's about the 1 centimeter mark, which more fits with a LVOT trace. But the kicker in all of this is we start to get, as you said, that there's mid-ventricular obstruction. And as Hatim was just saying, is that we've got continuous wave Doppler. Whenever we use continuous wave Doppler, the computer assumes that you are perfectly in line with that flow of blood. I could argue on this, we don't have color Doppler on this trace to help us guide that. We might be a little bit off, in which case we could potentially underestimate the jet velocity. The next thing to say, though, is that with continuous wave, we are picking up all the pressures right the way down it. And all that is being displayed on this profile is the maximum velocities. So my question for Ramsey, I know, hang on, this would be a great one. Lewis, let's get you into this, buddy. Danielle, there you are, all hiding down at the bottom. Fantastic. So let's get you guys into this. Right, Lewis, so you've got pressures here of first, so we're at 3.8 meters per second and a mean gradient of 63. So, sorry, we've got 5.4 meters per second, that's severe, a mean gradient of 63. What do you think of those valve gradients in this context?
So, as Ramsey was saying before, I think they're probably subject to some inaccuracy because of the hypercontractility of the LV.
Yeah.
But they probably represent severe aortic stenosis given the 2D picture.
Yeah, I agree with all of that. Why are they inaccurate though? This is where the crunch comes. This is the bit that I don't know whether it would be pass fail on this question.
Okay.
Would be for the gold mark bit. So I agree with probably dealing with severe aortic stenosis, but why am I harping on? What about these gradients? Why are these gradients potentially inaccurate?
So they're calculated on the basis of the velocity. So the LVOT velocity, the modified Bernoulli equation.
Beautiful.
Cross-sectional area, velocity 1, velocity 2.
Beautiful. And what's velocity 2?
Velocity 2 is the velocity just distal to the aortic valve.
Yeah, or approximately. It doesn't. Yeah, I guess V1 versus V2. Yeah. Otherwise, yeah. So because this is before it. So you're right. So yeah, sorry, V1. So let me ask V1. So what's important about V1? Because 4V squared is a modified Bernoulli equation, which is what is being used here to estimate pressures. So if we got a Vmax of 5, if you do 5 squared times by 4, you get 101.6 millimeters of mercury.
Yep.
And that's using the modified Bernoulli equation. So why is that potentially wrong?
Because V2 is more than 1.
Yeah, right, there we go. Fantastic. So it's more than 1, and that's what I was trying to get at with this picture here. Okay, so there's 1. All right, and clearly we've got gradients in that mid-ventricle area that are greater than 1.
Yep. So if you're using the Bernoulli equation, you need to include the velocity if it's greater than 1.
Fantastic. So this is where we've then got to take the 1.4 meters per second. Maybe I don't have the best case. It'd be nice if it was more than that, so it was actually significant. I'd take the 1.4 meters squared, I'd have to square that and then take that into the peak gradient that I've got from my aortic valve here. So we've got to minus it. So we've got to do 5 squared minus 1.4 squared times that by 4 to get our mean gradient, to get our max gradient.
Yeah.
And that's the importance of this question, I guess, to try and that's,
yeah.
So when you're looking at something like that, and we've got obliteration of that end systolic cavity, just like Ramsey was saying, I want your brain to start thinking, well, hang on, if we've got this hyperdynamic LV, we're either going to have a low stroke volume, or we're going to have a super high stroke volume, or we're going to have a super high mid-ventricle or LVOT gradient to take into account to figure out the aortic stenosis. Okay?
Yeah.
Nice. All right, so yeah.
Can you
I
just
think the terminology is we use the
Oh, sorry, we got 2 people talking. Just hang on a sec. Just Visha was saying something.
Can you please open that same image again, the gradient one, the aortic valve? Just one point, just one. Because I think the Doppler angle is also not very correct, because it looks like there's a sigmoid septum, which is, I think we
Very
need
nice.
to take in the side, before calculating.
Very nice. Okay, so let's just take it back a few sections. Just go back to basics just a little bit. So if you're being asked about aortic valve stenosis, we've got the 2D pictures that we can look at, and the 2D picture would be looking for signs of LV hypertrophy, LV systolic function, and I guess gives you an idea whether you've got a bad functioning ventricle or a potential for a hyperdynamic circulation. So those would be the advantages of using 2D. I think the disadvantages of using that are things like you're only assessing it in one plane. So for things like planimetry, it can be inaccurate. You're looking at a 3-dimensional structure with a 2-dimensional imaging tool, so you've got to look in all different angles to assess systolic function. And the last thing I'd say is that you've got to have an accurate view of the LVOT in 2D pictures to start estimating stroke volume if you want to work out what the valve area is. So those are the good and the bad things about 2D assessment. Next thing we'll talk about pulse wave Doppler. So pulse wave Doppler can be really good because it can pick up your LVOT VTI. And it can also help tell you what gradients are, for example, in the middle of the ventricle if you think that someone's got some form of obstruction. But it's a Doppler, so it's got to be angle dependent, and you've got to make sure you're imaging correctly. Am I imaging correctly on this view? No, why not?
So the closing click's not present.
Fantastic. So we've got to make sure with all of it that we're imaging correctly. Now, you've got to have accurate imaging to make an accurate interpretation to accurately put it into the patient's management. So yeah, the next thing is, I guess, with the pulse wave Doppler, you've got to make sure your angle is okay, and you've got to make sure you've got a closing click, because you've got to make sure you're measuring the LVOT at the same place in your 2D image. Beautiful. And it's not traced very well either. Yeah, fair enough. I did a very good job anyway. No, fantastic. I don't think these are my pictures. I'll say that. I was just reporting the image. It wasn't me, Your Honor. Fantastic. Okay, and then we'll talk about continuous wave Doppler. So the good things about it is they can pick up the high velocities that we'll see, greater than 2 meters a second that we'd see in any kind of significant aortic stenosis. It can pick up the max gradients, the mean gradients, which is what we often use. The problem is that it's flow dependent, angle dependent, and you've got to make sure you're picking up the right thing. You're not measuring mitral regurg. You're not discounting some LVOT or interventricular obstruction. And you're going to take the maximum gradient. So this is where things like the PDOF probe, if you might want to mention that, if you're looking at aortic stenosis, you've got to look at it from every angle you possibly got. So that the big ones for me is obviously the 5-chamber view. You've got to use the 3-chamber, and you've got to use the suprasternal. If you've got a sonographer who can use their PDOF probe, I'm not great with it. These are the kind of cases, if I'm ever sitting on the fence, formal echoes, asking a sonographer to work their magic of PDOF probes is the potential go. And maybe I could show you, if we've got time, to show you some examples of that. Cool.
Sam, I have a question.
Sure.
What do we do when there is atrial fibrillation, or there is
Great question.
changes in the measurements, beat to beat variation?
Yeah, I think it's difficult. I think you've got to take an average of 5 beats. So taking an average of 5 beats and using that. And I know in sinus rhythm we normally take the maximum one that we'll find in sinus rhythm, but I think we can do that. So we can do that dimensionless severity index, which I'll try and find a good case of that in a second. So the dimensionless severity index I really, really like, because it's a great way of trying to take some of the hemodynamics out of the equation. So that's the tip and the trick for this, which we'll get to on the next case, is that dimensionless severity index. So in cases of either low flow aortic stenosis or pseudo aortic stenosis, where we've got a low stroke volume and a high gradient, you've got to be using a dimensionless severity index. And what's the cutoff? What's the magic number? Have we got, Danielle, what's the magic cutoff for the dimensionless severity index for aortic stenosis? What indicates severe?
Is dimensionless severity index the same as the velocity ratio?
Yeah, totally.
So
Velocity ratio, no, hang on. So with the velocity ratio, do you mean to say the Vmax velocity is in the ratio between Vmax and the LVOT and Vmax and the aortic valve?
yeah, is that what that is?
It's actually looking at the VTI, so it's comparing. That LVOT with
VTI LVOT with VTI aortic valve.
Yeah, so here I'd be comparing 29. The LVOT is 29.
Yeah.
And if we didn't have LVOT obstruction, I could, mid-ventricular obstruction, I could use that VTI as well.
Yeah.
So 127. How do you do the calculation, and what's a marker of severe?
I'm not sure. Is it 0.25?
Very
Is
nice.
it that one? Yeah.
You can use it. We obviously, I'm so bad example. You can't use it in this case because of the mid-ventricular obstruction.
Sure.
But if we didn't have that, you could just compare those two, and you just divide 29 by 127, and if it's less than 0.25, that's a marker of severe. And that's a really useful parameter if you've got low flow or pseudo aortic stenosis. Nice. Let me just remember the name of the next case just in a sec.
Many years ago, we used to you could use either the ratio of the peak or the VTI, but it seems to be now we use VTI as standard.
I think that's absolutely.
Okay.
I think I got the same.
I remember reading 10 years ago, you could use peak, and then they.
Okay. It's basically just assuming that in a normal person, they'd be kind of similar to each other. Is that?
Very close, yeah.
Yeah.
Yeah, greater than 0.5.
Sorry.
All right. Harvey Bay, do you want to have a go at any of this, guys? The guys up in Harvey Bay, would you like to have a go at some of these? Can you hear me up there? In the Harvey Bay?
We'll skip this one. Sam, we'll just
No.
watch. We've just had a.
No problem at all. No problem at all. Lewis, do you want to crack on this one then?
Yeah, can you hear us?
Yeah, absolutely. I can hear you. I can hear you. We'll leave it. I'll hassle Lewis over in Fiji. He's in Fiji anyway.
I've got Luke with me as well. So
Hi, Luke. How are you going?
Good, thanks.
Nice one. We're just obviously talking about aortic stenosis. Lewis, let's have a go down this one for me, and tell me what you think about this picture.
yes, it's paracentral long axis. The major finding is the aortic valve. Once again, there is evidence of calcification with
Sorry, off axis on the first one.
poor leaflet opening.
Yeah, sorry, I'll leave you like that. Yeah, sorry.
The LV walls are thin and contractility seems reduced.
What walls of the ventricles are we looking at here?
So there's the septal. So there's the so I'm never good at this. This is the anteroseptal, the anteroseptal,
The
basal septal, mid septal, and then posterolateral and basal.
Yeah, no.
Mid and basal posterolateral walls.
So again, in the exam, we are going to ask you that.
Yeah.
And I recommend you don't start off with going, "Oh God, I'm bad at this." So, so we'll just start off. So it's totally cool if you've got to take your time, because I have to all the time, and I have to think about the two chamber and how I got to the two chamber view, and then work my way back from that, from apical 4 to 3. And so this is the apical 3 chamber. That's the same as your parasternal long. So I must be looking at my my anteroseptal walls and my inferolateral. It's not the posterolateral, it's the inferolateral walls.
Yeah.
And yeah, so just make sure that's just coming out nice. So every time you're going through an echo, just get the walls. We're going to ask it to you. If you get it wrong, everyone freaks out.
Yeah,
okay?
I'm still doing it in my head. Fortunately, I'm getting there.
That's fine. It's fine. Just keep going. It's good, because that would have I just answering like that as well. I was going to say is would raise alarm bells with some of the examiners. So just keep that. Keep practicing that one. Fantastic. What do you think about the regional wall thing? So you talked about the basal and the medial. The basal and the mid segments of the anteroseptal wall. What do you think about the regional wall motion analysis?
So it looks like the basal segment's contracting.
Mm-hmm.
The mid anteroseptal looks almost dyskinetic. Looks like it's dyskinetic, and looks like
dyskinetic means it's going in the wrong direction during systole. Again, we can argue about akinesis versus dyskinesis, but it certainly doesn't look normal. So where do you think I'd be going with this question? If I showed you this first up and we're seeing a bad aortic valve, I'd probably give you a better picture, obviously.
Yeah.
Where do you know I'm going?
So this is going to be a aortic stenosis in the context of a failing LV.
Nice. So you got to know that I'm taking you down the low flow aortic stenosis route. So I'm probably going to show you gradients that are not severe. That there's got to be a low stroke. Potentially there's a low stroke volume coming with this. Is it hemodynamically significant? Well, it's all about putting that into context. But if a guy is hypotensive with this, you've got to be thinking that gradients might increase. If you're putting this guy on any kind of inotrope, it'd be almost like doing a dobutamine stress test and seeing if we've got any myocardial viability and any reversibility to the aortic valve stenosis.
Suggesting the Dementia Index over any other.
Very nice. And why is that? Why? Let me. No, sorry. Then I'd show you a picture like that.
Okay, so the Vmax is consistent with a moderate aortic stenosis. The pressure gradient consistent with a moderate aortic stenosis. The max gradient should be over 40 to qualify as severe.
Yep.
But like I said, you would take these numbers with a grain of salt given the LV appearance on 2D. The VTI was, where's the VTI?
So the which one for the aortic valve?
LVOT VTI, yep, the aortic valve.
So let me ask everyone to estimate what the aortic valve area is. So let's do it together, okay? So first thing you're going to need is the aortic valve. And you want it in a zoomed in view, because that means you're going to have the most accurate measurement. You want to have a couple of cardiac cycles to play around with. You want to find it at mid-systole. Yeah. So find the best cardiac cycle you've got. It's probably about as good as we get. And I'm looking for the cusp insertion points. So if I go dimension, LVOT diameter, I'm going to go from one cusp insertion point to the other. Yep. Okay. So we've got an LVOT diameter of 2.2. Okay, next thing we're going to have is the LVOT. And I got an LVOT VTI of 26.6. And ideally you take 3 and take the average of them. But let's just say 26.6. Then I've got an aortic valve VTI of 62.4. So my question for the group is, tell me what the aortic valve area is and how you've got it. Let's just give everyone a bit of time to figure that out.
Comes to 1.6.
1.62.
Oh my God, have you there already?
Yeah, it's just less than 1,
Why do you get
like
that?
0.98 or something.
Hang on a minute.
2.2.
Did you get?
1.62.
Yeah.
1.61.
So I got
1.619, so 1.62.
We can argue about the 0 1 there. Fantastic. So hang on. So some people were saying it was less than 1. Talk to me. Let's just go through it a little bit. So you've got to make sure you've got the LVOT diameter, square it, and then I times by 0.785. Sorry, the
LVOT radius.
Oh, yeah. Sorry, yep.
do 0.785 times LVOT squared, or you could do pi r squared and divide it by 2 and square it. So you just take the LVOT diameter or radius, and whatever calculation you want to do with pi is to get the area. And the problem with that is, of course, you're saying that it's a circular structure, and obviously it's not always a circle. Sometimes it's an oval, and we don't know. So that's where, first of all, that's one of the main errors that occurs, which is why you've got to do it in that zoomed up view, and you've got to take 3 cardiac cycles and measure it as accurate as you can, because that error, if you make it, is then squared. All right? So that's the first error that we've got to be careful of. So once you've got the LVOT diameter, or area, excuse me, you then times that by the LVOT VTI. So we then times that by 26.6. And that is going to be equal to the aortic valve area times by the VTI, as long as there's no LVOT subvalvular or left ventricle obstruction or obstruction in the ascending aorta. Yeah? Okay. And then that means you can do the LVOT area times by the LVOT VTI divided by the aortic valve VTI to get your 1.6. So I guess that's the thing that we've asked that in the exam before. So you'd be expected to be able to do that equation in the heat of battle. I'll probably give you some better numbers than that, but it's the kind of thing that you'd be expected to do for the aortic valve, mitral valve. Would probably be the 2 big ones. We might ask you to do that equation on the spot. Okay. All right.
So sorry, what was the answer?
1.6
Okay, yep.
or 1.619 as Vishal said.
So there's a discrepancy between, there's a discrepancy based on the area versus the gradient in terms of severity, right?
Yeah, so why is that? Why? It's very nice. So we just had the argument is there's a bit of a discrepancy based on the area versus the gradient, because, tell me why, just explain a bit more.
So again, like, as you already mentioned, so there's a low flow state, so low gradient, low flow, severe aortic stenosis. So there could be few reasons behind that. So first is the alveolar diameter.
Yep.
So if you overestimate alveolar diameter, you can get that.
Yep.
And the body size matters. So I don't have the what's the body size. If it's a large body area, then you can get that. Oh, sorry, other way around, small body area.
Yeah, very nice.
If there's associated mitral stenosis, mitral regurg, then you can have that.
Yeah.
And that's enough, I think.
Yeah. So I get so I guess we talk about the inaccuracies of doing the continuity equations. Vishal was saying is that first of all, we're assuming that the LVOT is circular. Second assumption is we're assuming that we're making an accurate measurement, and if you over underestimate it, we can under or overestimate it respectively. We've got to make sure that you've got the same amount of blood volumes going through the LVOT as going through the aortic valve. So if you've got significant mitral regurg, or you've got any kind of left to right shunt, that can impair it. And then I'm going to also add in the idea that the next problems that you can get is that you're using your Doppler, that you make sure that your pulse wave Doppler is in the same position as your LVOT, and that your continuous wave Doppler is in the right alignment, and that you've got no form of obstruction anywhere else other than at the aortic valve level. So the aortic valve is the maximum gradient there. Okay?
Sorry, just to clarify, the mitral regurg is an issue if you do the mitral stenosis, right? Or
if you've got significant mitral regurg and you're doing the aortic valve stenosis, I still think that you can have problems. I don't think it's significant, and whatever the hell that means. I don't think you can assume that the blood flow through your LVOT is going to be the same as your aortic valve. Do you agree? I mean, because you've got to have some that can come up, won't you?
Just trying to think. I think it's the other way around. Like, you can't use it for grading mitral stenosis if you have
it's an aortic regurg. Absolutely, I completely agree with that. But wouldn't you say the same thing with? Could you?
Because it should be the same stroke volume going through the LVOT.
But only if it doesn't
right
fall
next
out
door to
through
each
the
other.
During systole, some of that blood goes
there
back
might be a
through the
measurement.
mitral.
Yeah.
But then the problem with that is it's only the blood going through the LVOT that goes through the aortic valve.
Can you? Everyone can hear this, right? The debate. Yeah. I guess the argument is that if you're measuring right here where my marker is, if you're measuring the stroke volume that's coming out of there, but you've got significant regurg that's going through here, could you assume that the blood volume that you have here is the same as the blood volume that you've got coming through the aortic valve? I'd lean towards the idea that it might not be accurate there, but we do have debate about that.
Isn't it that, I mean, the LV cavity looks a bit dilated in this patient, and isn't it just the fact that the LVOT VTI is higher than what we would have expected it to be, looking at that ventricle? But actually maybe the stroke volume is higher than what we would expect because of the fact that even though the LV is contracting poorly, it's a bit dilated to begin with.
Yeah, very nice, absolutely. And I guess that's where the idea that ejection fraction and stroke volume are very different, and depending on your afterload and the size of your left ventricle. Yeah, I completely agree. So maybe just in summary to wrap it up at the end, I think we just, when you're talking about aortic stenosis, you've got to know the advantages and the disadvantages of every single marker. You know, we obviously love asking about this because I think if you get this, you get echo and you understand the nuances of it, because sometimes the parameters don't match up, and that's where you've got to take in that idea of seeing the whole heart. And yeah, we're going to ask you about this in some way, to be honest, in the exam. Okay, are there any questions or comments? Nice way to end, talking about the controversies about that, I think.
Sam, I had a question.
Sure.
When we measured the LVOT at root of the annulus, root of the insertion of the valves. I have read somewhere, and some people have also mentioned that we can actually do a measurement around 5 millimeters.
Absolutely, and I was going to mention that and didn't. It's in Benita Anderson's book is where you read it, and she says in her book you go back 5 millimeters. So instead of measuring at the annulus, so on something like this view here, if I paused it, found it at mid-systole, it's probably better on that one there. So mid-systole, there are two measurements that we could potentially make. One is from where the cusps insert, so it's probably there and maybe there. Yeah, so 2 is about right. Or you could measure it 5 millimeters back in, which is say there from there. So these are the two areas. The way I was always taught is to do it at the cusp insertion point. This is the way the guys do it at the Mayo Clinic, is because they say that if you measure it at that point there, you can make sure that when you're then in the pulse wave Doppler, you're looking for that closing click. Yep, that closing click happens because these mitral valve leaflets are closing, and you just get this little ejection of blood that comes back down through. And so if you're getting that closing click, but you don't have your opening click, that lets you know that you're sitting right there. In the exam, we'd mark both as being correct. I think in the in Benita's book and in the ASE guidelines, they both talk about being 5 millimeters proximal to the LVOT. So they both talk about being there.
In the aortic stenosis guidelines, they clearly state that both are valid, both have advantages and disadvantages, and in fact, you can go up to a centimeter back because there's often very little variation. So I think all of these are valid methods, and I agree. Going close gives you the advantage of the click. It gives you reproducibility, but it says it's perfectly reasonable to come back because often you have to come back. You have to pull back your. It more accurately represents where we tend to put the.
Sometimes the valve leaflets are so heavily calcified, it's quite hard to see where the insertion points
I was
are.
going to say exactly that.
They're all
Yeah,
valid.
Yes, I don't know.
Yeah, it's one of those minor debates in medicine that goes on forever.
And that's why Malcolm All is correct. I think if you can have a debate in it, then you know your stuff. All right.
Nice in the AS guidelines, the current ones.
Yeah, I think you probably do better to go with the ASE guidelines than what Sam says.
What you said was perfectly right, though.
So in the exam, if we say, but Sam said.
No, that's a fail, automatic fail probably. Depends who's answering it. If it's me marking it, I'll definitely say it's right.
You'd probably say Benita said. That would probably carry weight.
Yeah, definitely. All right, guys, thank you very, very much. I'll see you next week.
Thanks, Sam.
All right, bye.
Thank you.